The first thing I'll say, thank you so much for the invitation to be here. It is a joy to be in Croatia, and it's fantastic to be at such a great meeting. So thank you so much for having me. I'm going to talk about this. I have no disclosures or conflicts related to this or indeed any other presentation. And I've got three parts to my presentation. First, I'm going to talk about diagnosis and recognition of cardiogenic shock. Then I'm going to give you some key considerations in treatment decision making, and then talk a little bit about pharmacology. So that's what we're going to talk about. So when we're thinking about recognition of cardiogenic shock, these are the 2021 heart failure guidelines. And they've got here at the top all of these acute heart failure things related to the left heart and the right heart. And there's this line here which is about hypoperfusion. Now this is the key. The concept that you are well perfused and then you gradually become less well perfused, and if you get better, you get better perfused. So the definition of cardiogenic shock no longer includes hypotension, it includes hypoperfusion. And that's in the recognition that about 20% of the patients in the original shock registry were normotensive. And we all know, we see patients who've got normal blood pressure and look awful. So hypoperfusion is the thing. And I'm going to talk about a patient, because we talk very abstract, so I'm going to talk to you about a complete disaster that happened to this young lady, and I share her picture with her parents' permission. So Lucy was 17 years old. She was fit and well, she was a gymnast, she was an identical twin. So she had a twin sister exactly the same. And Lucy, one weekend, said to her mother, "I don't feel very well. I've got a sore throat, I've got a temperature, I feel really bad." And her mother was a very sensitive, she's from Wales, so Welsh women are very strong, and they're very much with their children, just behave well and don't make too much noise. So she said to her daughter, "You'll be fine, don't worry about it." But by Monday morning, Lucy was really clearly not very well. So her mother took Lucy to the primary care practitioner, to the general practitioner, and the GP looked at Lucy and went, "Oh, you don't look very well." So Lucy is taken to her local hospital, which is a small, ordinary district general hospital in Wales. So this was her story, 3 days of being ill. She turns up at the A&E. She has a lactate of 4. She has an elevated white cell count, she's hypotensive, and it was at the height of the Surviving Sepsis campaign. So everybody in the emergency department goes, "Oh, this is sepsis. She's young, she's got a temperature, she's had a sore throat, she's got an elevated lactate." So they gave her a lot of volume. So they gave her 7 litres of volume resuscitation. She's quite small. Her lactate kept going up. They started her on Pressols and inotroches. They did a CT. They couldn't find, they thought it was abdominal sepsis. There was nothing wrong with her CT. But they did see a pericardial collection, so they did an echo and they did a pericardiocentesis. They were absolutely convinced that she had sepsis, so they took her to the OR and they did a laparotomy, which was negative. She continued to deteriorate. She had a cardiac arrest at 11 o'clock the next morning, from which she couldn't be resuscitated. And at that point, they reviewed the echo and went, "Oh, her LV and RV function is terrible." And they asked for the ECMO team to come halfway across the country to try and save her life. And of course, it was too late. So our questions to the team, and this was not in a blame type thing, it's how do you get it so wrong? I mean, really, you've got a terrible echo, you've got an elevated lactate, your biomarkers are all wrong, she's got multi-organ failure. How do we get it wrong as doctors? And when you spoke to the team, there were some things that were recurring themes in the multiple teams that managed this little girl over a few hours. So firstly, the big one was they never thought she would have anything wrong with her heart because she was young and fit. How could she have something wrong with her heart? And that, I think, goes to the messaging about who gets coronary disease and who gets cardiovascular disease. And young people get cardiovascular disease. There was a recognition that she was clearly hypoperfused, but nobody really acted on it. They didn't understand why she didn't get better, so they were using the sepsis care bundle because everybody was treating her for sepsis. And there's this very slightly, I would say, passive-aggressive thing that we say the patient fails to respond. Well, if the patient fails to respond, it's probably because we're doing the wrong thing. It's not really the patient being difficult. So they were doing the same thing again and again. She wasn't getting better. And then you begin to try and understand, why do we do this in medicine? I think this is important for cardiogenic shock because it's difficult to recognize, and we have to understand why we get it wrong so often. So, the first thing is, can I go back? Here, these are what we call cognitive dispositions to respond. These are our biases as decision makers in the acute and chronic setting. So what happened with Lucy was somebody decided she had sepsis, so everybody agreed she got sepsis, and they carried on saying she has sepsis. They didn't have a differential diagnosis. They didn't say that it might be sepsis or it might be something else. They just went, this is sepsis. And if you look at medical negligence and litigation claims in the United States that are successful, the first cause is failure to have a differential diagnosis, so always have a differential. Every time she was handed on to somebody else, they always just inherited somebody else's thinking. They had the prevalence perception. Young people don't get cardiac disease, do they? She had certain characteristics that made everybody think she was fit and well. Well, she was fit and well. And then there was a little bit of problem with the big boss saying, no, this is sepsis. Nobody really looked at the echo, and when they said it was normal, everybody went along with it. So all of these things are things that we do all the time. So the first thing I'd say in the cardiogenic shock is the recognition is everything. And we do have various things that can help us. We have biomarkers, we have lactate. We do have scores that are relatively well validated in the critical care setting that suggest hypoperfusion. But I would suggest that most of us don't use them, don't recognize them, and don't recognize how important they are. Temperature differences or temperature gradients between the periphery and the central patient temperature have been validated over half a century in patients, and there are now different ways that you can detect it, but the cool patient who is mottled and has even the slightly elevated lactate or a normal lactate, they are hypoperfused. And then of course we can measure the cardiac output index. And then this is easy to read if you're English, but less easy to read if you're not English. So this is one of the charts that they use at the ophthalmologist. And the problem with these guys, and with all of us, is that we rarely see what's right in front of you. So make sure you look at the patient, and if you think that you have hypoperfusion, and you can see that there's a primary cardiac problem, that patient has shock. Don't call it anything else. They have a very high mortality. They're going to do badly unless you reverse the underlying cause and support them. Okay, so when you're thinking about cardiogenic shock, and this goes back to a little bit about what Christian was talking about, so he focused on the C, D and E. I think we need to think about the A and B, because Lucy didn't have particularly high biomarkers. She wasn't particularly hypotensive, but she became it very rapidly. And in the 2022 update on the SKY classification, what they do is they comment about rapid progression between one or the other, and that the patient, what you want to have in front of you is whatever you're doing, the patient moves in the right direction. If they're getting worse, then you need to rethink your strategy, and understanding that there is a spectrum of cardiogenic shock and the patient can move within the spectrum. One other thing I'd say to you is if you see a heart looking like this, I don't mind whether their blood pressure is normal, their lactate is normal, their liver function, their renal function is normal, and they're cerebrating fine. You can guarantee that they won't be in about an hour or two's time. So if you see an echo like this and everybody's going, yeah, but the patient's fine, you know they won't be, especially if they're young. So do take a look at your echo and take it really seriously. This was her echo. Okay, then this is my chain of survival in cardiogenic shock. It's a bit like cardiac arrest, but in slow motion. So the first bit is recognition and getting specialist input. And I think we don't spend enough time on this. And I think we as cardiologists and cardiac intensivists need to make sure that we do. Davor is going to talk to us about mechanical circulatory support, which is fantastic. And I'm just going to talk a little bit about support and intervention, because these are the other bits of the chain of survival. From the 2021 guidelines, we're told to find the causes for cardiogenic shock and address them. And as you heard very nicely from Christian Hassiger, the etiologies are changing, and we're seeing more and more non-ischemic cardiogenic shock. And for that reason, these now have equal billing right at the top of the algorithm. You may remember in the old one, the other diagnoses were down here. Now they get equal billing up front. And in any cardiogenic shock program, you need to be able to address absolutely everything. You need to have the experts immediately available. So you need to think about pericardial cardiomyopathy, you need to think about reversing your arrhythmias, pulmonary embolism, of course coronary disease, expert access to inherited cardiac conditions, the people that deal with cardiomyopathies, and of course myocardial dysfunction in sepsis. And again, speaking to the question about Davor said about COVID-19, we saw 3 different types of patients with COVID-19 cardiogenic shock. The first, which was really unusual, was acute myocarditis. We didn't see that very much in London. The second is sepsis-related myocardial dysfunction with profound shock 2 to 3 weeks after COVID infection. We saw that a lot, particularly in the second wave. And the third was profound right ventricular involvement, particularly in the first wave of COVID in patients on the intensive care unit, and it could really cause quite profound shock. So you need to know the different etiologies, and you need to be able to address them with your expert team very, very rapidly. So having done that, what can we do? So we're talking about ventilation. Guido gave you a great overview. Do read this. It is a fantastic overview of mechanical ventilation in cardiogenic shock. It's in Current Opinion in Critical Care from 2021, and it is a really, really nice overview. You heard some of it earlier today, but go and take a read. I'm now going to talk, though, about inotropes and vasopressors. This is a great article. It's from 1965, so it's a little bit old. But what is really disappointing about it is really nothing has changed since 1965 in the way we use and apply inotropes. So you look at about this, the primary purpose of this article is to differentiate drugs belonging to these groups: vasoconstrictors, cardiac stimulants, and vasodilators. So nothing's changed since 1965, but I'll try and give you an insight as to some things that might be useful to you. In cardiogenic shock, hypotension is probably bad for you, but we don't know what level of blood pressure, and the balance between flow and pressure we know is challenging. In theory, we know that, say you had a type 1 myocardial infarction, your LV-EDP goes up, and you become profoundly hypotensive, and you drop your root pressure and you increase your LV wall tension, you're going to get a reduction in your coronary perfusion pressure, and you will get a type 2 myocardial infarction on top of it. There are only 2 things you can do in that instance: increase the blood pressure and increase the flow. This is a small study. It's observational, but it tells us a couple of things. The first is it tells us that periods of reduction in cardiac index and cardiac power are bad for you in cardiogenic shock. And the other thing it tells you is that the cardiac index that you regard as a threshold is not 2.2 for every single patient. It depends on the acuity of the presentation, if it's acute on chronic, and the underlying etiology. So not all shock at all is the same. This is one graph that I give to all of my juniors because they get worried about, is it beta or is it alpha or whatever. So this is a great one for teaching. These are the drugs that we have at our fingertips. This is your alpha receptor, this is your beta receptor, this is the effect on cardiac output, this is the effect on the blood pressure. So it's a great one for teaching when you've got your juniors in front of you. And then you can also look at a sort of 2-axis thing here. So you've got positive inotropy here, vasoconstriction up here, and vasodilatation down there. So all we're doing when we're using these drugs, and when you try to explain to your juniors how to use them, it's balancing the abnormalities in your circulation that you have and trying to correct them. It may not be the right thing, but it's all we have at our fingertips at the moment. So talking first about vasoconstriction, all the recommendations are for norepinephrine. Mostly they come from this study, and I'm just going to signal a word of caution. So this is the SOAP study. It was nearly 1,700 patients with shock, of whom only 280 were cardiogenic. And the conclusion for the cardiac patient was that maybe noradrenaline is less harmful than dopamine for these patients because of fewer arrhythmias. But if you look at the study criteria and how they defined shock, there wasn't actually an operational definition of shock. There was no evaluation of any treatment differences across the hemodynamically very diverse phenotypes. Nothing in there about myocardial infarction or what type of heart failure they got. Nothing about time-related evaluation of treatments, or indeed any of the hemodynamics that they got. So this was not a trial that was designed to look at patients with cardiogenic shock, but it's one of the largest we've got. And when you look at what norepinephrine does, you've got norepinephrine here, inoxamin here, dobutamine here, it does what you want it to do. It increases the systemic vascular resistance and it increases the mean arterial pressure. And it sits there still in the 2021 guidelines for acute and chronic heart failure unchanged. So norepinephrine is still the first vasopressor of choice. We are beginning, though, to try to understand how much harm these drugs are doing to our patients. And if you're trying to look after the heart, maybe norepinephrine isn't a good thing. This is Caroline Bleakley, who's a fantastic clinical cardiologist and echocardiographer. And she uses a large number of really advanced echo imaging techniques. And what she did was she looked at the norepinephrine dose in critically ill patients, and she looked at myocardial blood flow using echocardiography, and also looked at global longitudinal strain. And what she demonstrated was, independent of the mean arterial pressure, the higher the norepinephrine dose, the worse the myocardial blood flow, and the worse the global longitudinal strain. So it may be that we're making the numbers at the bedside look fantastic, but actually we're harming the very organ we're trying to look after, the heart. Of course, all respect to the other organs as well. Okay, what about positive inotropic agents? So we increase the mean arterial pressure because that makes us feel better, and then we reach for inotropes. Now, inotropes are interesting drugs. They are all very, very different. They all increase DPDT, they all increase contractility, but remembering what we have talked about, this inflammatory response that you get in cardiogenic shock, think about these other effects that you may see. So these inotropes have differential effects on the macro and micro circulation. They have immune modulatory effects. They alter bacterial metabolism and translocation. They alter reactive oxygen species. So they have profoundly different effects. So not all inotropes are the same, and we don't measure any of these things, but they're probably important in cardiogenic shock. And then when you look at the effect of dobutamine, so here we go, fantastic drug. Yes, it increases the cardiac output and index. The lactate goes down. But the effect on the microcirculation is nothing at all. And we've heard that the microcirculation might be important. So when choosing these drugs, we're really working in the dark. We don't know what we're doing. We don't know what we're doing to the micro and macro circulation. And as Guido Tavazzi told you in his very nice presentation earlier, this is the study from Derek Gibson looking at coronary artery disease and dilated cardiomyopathy. And in the patients with coronary artery disease, the use of dobutamine was associated with worsening of stroke distance from the ischemic, presumably ischemic hearts that we cause. So we can cause harm not just with norepinephrine, but we can also cause harm with dobutamine. And if we don't go looking for it, we won't know what harm we're doing. Adrenaline is getting very bad press. This is just from the Cardiologist study saying it's probably a bad thing to give to patients. This is Philippe Vignon's study. It is not a perfect study by any means, but again, the signal for harm in the use of adrenaline is coming from more and more studies. And so it's been really taken out from the guidelines. Not to say you should never use it, but it shouldn't really be the first drug that you reach for. And the realities of what are happening is this. So that's very nice. It's an abstract. This is a nice study that Guido Tavazzi and a group from Acute Cardiovascular Care did. They looked at 60 countries across 4 continents and said, right, what are you really doing in your cardiac intensive care units? So how do they manage cardiogenic shock? So the management, so catecholamine titration, mechanical circulatory support, driven by mean arterial pressure, echocardiography, lactate, so they're all pretty well the same. A bit, again, answering the question earlier, invasive cardiac output measurement, about half of them, of which 3/4 of this half use pulmonary artery catheters. So that's the reality of what we're doing. And when we look at the drugs that are being used, combinations of vasopressor and inotrope chosen with the same frequency. NORAD is the first-line vasopressor, well, that's in the guidelines, followed by dopamine, probably the surgical units, if it's anything like the UK, and dobutamine is the first-line inotrope in the majority of respondents. So that's the reality. If I think about the future, this is what I think we should be doing, but we're not going to be able to do it without machine learning, artificial intelligence, and beginning to look at our patients in a really, really different way, which I think I'm going to talk about on Sunday. So what you need to do for each inotropic agent, the established ones and all the new ones that are coming out, is to think about the pathological situation you're in. We've heard that not all shock at all is the same. We need to understand each organ system and each circulation, including the microcirculation, because the differential effects are there. And for each of them, we're going to have to plot out, in effect, a log dose efficacy versus toxicity curve and try and find the sweet spot for each different organ system and how do we balance one off against the other. So that's for the future. What about now? What's the reality now of how we can use these? The practicalities for me are really these. To try to address the hemodynamic inadequacies. Don't just get fixated on pressure or flow, but also think about venous pressure. We're going to have to individualise what we do for our patient care and our decision making. We need to monitor to look for effects, beneficial or otherwise. So don't just institute a therapy and think, well, that's enough. Use appropriate cardiac output monitoring. Remember, these are probably not benign agents, in particular when we look at the heart. And then most importantly, and before I hand over to Davor, if your patient's getting worse, as I said at the start, it's probably not their fault. It's probably because we're on the wrong pathway for them and we need to devise something else. And when we've gone through recognition, we've done the support, we've dealt with the early intervention, we need to find a different type of support, and it may be that we need to escalate to something different. And with that, I thank you very much for your attention.